All right, if you're on the path to becoming a surgeon, you've probably pored over countless diagrams of the abdomen. But what if I told you the very map you've been using is, well, wrong, or at least outdated? In this explainer, we're going to give you a brand new map, a mental model that will completely change how you think about this incredibly complex part of the body. Let's get into it. So let's just start with a fundamental question. Think back to your anatomy textbooks, all those complicated piecemeal descriptions. I want you to forget all that for a second. What's the real organizing principle of the human abdomen, the one thing that holds it all together?
The answer? It's the mesentery. And listen, this is the key point. It's not a bunch of separate little ligaments and attachments like we used to think. It is a single continuous organ. And that's not just some cool piece of trivia, okay? Grasping this one idea, it literally changes everything about how you'll approach abdominal pathology and surgery.
Okay, so before you can even think about operating, you have to understand the blueprint, right? You need to see how this whole thing is put together from the ground up. Because really, every single surgical procedure is just you navigating that original design. So look at this. This framework simplifies the entire abdomen down to two basic domains. You've got the mesenteric domain, that's where all your digestive organs live, the intestine, pancreas, spleen, liver. They all develop on the mesentery and get their blood from its arteries. Then you have everything else, all the genitourinary stuff, the muscles, the bones. That's the non-mesenteric domain. Think of this as the first major landmark on our new surgical map.
So how does this all get set up? It's a process called adhesion. As we develop, parts of the mesentery basically stick to the back wall of the abdomen. What you end up with is this really elegant mix of mobile parts and fixed anchored parts. And no, this isn't just a boring embryology lesson. This architecture is why organs can move and twist and get diseased. And as you're about to see, when it goes wrong, it's life or death.
And here it is. This is exactly why that blueprint matters so much. If that sticking down process, that adhesion, doesn't happen completely, the mesentery stays too loose, too mobile. And that can be catastrophic. It can lead to volvulus, where the gut twists on itself, choking off its own blood supply. This is a code red surgical emergency, and it all comes back to that basic anatomical plan. All right, let's shift gears. We've seen the blueprint for a normal abdomen. Now let's look at what happens when things go wrong. If the anatomy is the map, then pathology, well, it turns the abdomen into a battlefield. And the main stage for that fight is the peritoneum. 2 square meters. Just let that number sink in. That is the surface area of the peritoneum. It's almost as much as your skin. Now, imagine that entire surface getting inflamed. When you're dealing with infection, inflammation, massive fluid shifts, you have to remember you're dealing with this huge, incredibly reactive surface. It's why things can go south so fast with abdominal sepsis. And the name for the main event on this battlefield? Peritonitis. It's what happens when there's a breach somewhere, a hole, a leak, a lack of blood flow. Bacteria get out, or chemicals, and it triggers this massive inflammatory response across that whole 2 square meter surface. Trust me, this is one of the biggest emergencies you'll ever see as a surgeon. So, what does this look like at the bedside? You need to recognize the signs of peritonism. Your patient won't want to move. A cough, a bump of the bed, it's agony. They'll have a fever, their heart will be racing, and when you examine them, you'll find that classic triad: guarding, rigidity, and rebound tenderness. These are not just symptoms, people. These are blaring alarm bells telling you a catastrophe is unfolding inside that abdomen. Okay, so what do? Your response has to be fast and it has to be logical. Step 1, resuscitate. These patients are losing a ton of fluid into their abdomen, so you've got to get fluids in them now. Step 2, support. Give them pain relief, start antibiotics, support their vital signs. Step 3, and this is the most important part, intervene. You have to get to the operating room and achieve source control. That means you find the source of the problem and you fix it. You plug the hole, you take out the dead tissue, and finally you cleanse the battlefield. You wash everything out. Resuscitate, support, intervene, cleans. That's the mantra. So, you've won the initial battle. You've controlled the source. The patient is stabilized. But you're not done. Now you have to deal with the aftermath. The body's own feeling process can, ironically, create a whole new set of problems. Collections of pus, blockages, and internal scars. Here's a classic surgical saying you absolutely have to remember. Pus somewhere, pus nowhere, pus under the diaphragm. What does that mean? It means when your post-op patient has a fever and just isn't getting better, but their belly feels okay, you have got to think about a subphrenic abscess, a collection of pus hiding under the diaphragm. And the big clue?
The irritation there refers pain all the way up to the shoulder tip. It's a timeless piece of diagnostic wisdom.
So, who's the hero in this story? Who tries to stop these disasters from happening in the first place? It's the greater omentum. Rutherford Morrison gave it the perfect nickname, the abdominal policeman, because that's exactly what it does. It moves to wherever there's inflammation, and it tries to wall it off to contain the infection. When you operate for appendicitis, you'll often find the omentum wrapped right around the appendix, literally doing its job.
Now, let's talk about the internal scars left behind by surgery and infection. We call them adhesions, and they're not all the same. You have these soft, non-vascular peritoneal bands that can cause a loop of bowel to twist. You get these flimsy, wispy adhesions that surgeons call angel hairs. And then you have the really tough ones, dense, vascular adhesions that can basically glue organs together. Knowing the difference is crucial when you have to go back in and operate again. And why do we care so much about adhesions? Look at this. This is why. They are not a minor problem. In developed countries, something like 65–70% of all small bowel obstructions, SBOs, are caused by adhesions. Just think about that. The single most common cause of this major surgical emergency is often the result of a previous operation. It's a sobering thought, isn't it? Okay, so let's tie all of this together. What's the big takeaway here? What does this new model of the abdomen really give you? Simple. It gives you the right map for the job. This quote really just nails it. A knowledge of the anatomical relationships provides the student of abdominal surgery with a roadmap by which to perform safe and optimal abdominal surgery. That's it right there. When you see the abdomen through this mesenteric model, when you understand the domains, the lines where things stick together, the fact that it's all one continuous structure, that is what gives you your roadmap. So look, all this knowledge, this is your foundation. But a map is just a map, right? The real test, the real challenge, is applying it in the real world, to the complex, unpredictable territory of a living, breathing human being. So I'll leave you with this question. We've given you the map. Are you ready for the territory?